Hi guys, this is Dr. Kavya and I'm back with a new series on mechanical ventilation. Now I have made this in a very different way, that is, it will be case-based ventilation. See, why I've chosen this method is because we all have learned ventilation so many times, but it is very difficult to apply this knowledge on an actual ventilator. Secondly, there are multiple videos available on YouTube teaching you basics of ventilation, but very few will be on pediatric ventilation. So this series basically aims at solving these two problems. Even if you are a MBBS student in your final year or you are just a first year postgraduate student in pediatrics, this series will still be very useful to you because we will be discussing cases. So case-based approach will also be there besides ventilation. So it's not just on ventilation, it's also on the cases. So let's dive right in. So let's start with the first case. This entire video is going to be on this case only. So it's a 14-year-old boy that has come to you or emergency with symptoms of somnolence, lethargy, and difficulty in arousing. For the past month, he has been complaining of tiredness, neck pain, early morning headaches. He was afebrile with shallow respirations with a rate of 10 per minute, heart rate 88 per minute, BP is 160 by 100. Pulse oximetry shows SpO2 of 90%. Pupils are 4 and briskly reacting to light. No evidence of trauma. There is a response to external stimulation, and the baby, your patient, is answering simple questions, but he went back to sleep. Rest examination, including that of the chest and abdomen, is normal. ABG shows pH of 7.2, PCO2 70, PO2 62. Supplemental oxygen via face mask was applied. 15 minutes later, he was found to be unarousable with barely discernible respiratory effort. SpO2 was 100%. ABG now shows a pH of 7, PCO2 of 100, PO2 of 120. This time, rapid sequence intubation was performed. Volume controlled ventilation was instituted with respiratory rate 18 per minute. Tidal volume 500 ml, TI 1 second, P 4 centimeter of water. Chest radiograph reveals a normal lung and heart, and ET tube is at mid-tracheal level. Now, I have just read a case to you, and this seemed very boring to hear, maybe, right? But we'll be discussing each and everything in this case. You should, from this case, you should again read it from this slide, pause your video, read it again, and try to identify the basic pathology. There is a respiratory failure that is happening here, but the cause of that respiratory failure, is it central? Is it pulmonary? Is it cardiac? What is the main cause behind it? Secondly, is oxygen, supplementing of oxygen, actually helping the kid or it worsened the situation? If it did, why did it do that? Ponder on these points and we'll be discussing each one of them in detail in the subsequent slides. So, the patient here has severe respiratory failure. Why I've highlighted it green is because there are two kinds of respiratory failures. We'll be discussing them in the further slides. The patient here has your severe respiratory failure. However, he shows no signs of respiratory distress. There is no particular physical finding except for weak respiratory effort. Even his chest radiograph and the heart findings are normal. So you see that there is hypoventilation without significant oxygenation deficit, suggesting that there is abnormality of alveolar ventilation, but the alveolar capillary apparatus is essentially normal. Now, this is a very complicated line for you, right? Now, oxygenation depends on various factors, which includes your ventilation as well as your vacuum mismatch, your shunting, your diffusion, all of that. Again, we will be discussing it with a diagram in the subsequent slides. For now, we have a kid with severe respiratory failure who does not have much findings in the respiratory or the cardiac part. His chest X-ray is also normal, so it seems to be a case of alveolar hypoventilation causing hypoxia. Now, what can be the cause of this alveolar hypoventilation? There can be either a central obstruction at the level of pharynx, larynx, trachea. There can be ineffective neuromusculoskeletal function or an abnormal central control of respiration. Now we have to see which one of these three is it. Now first let's discuss about central, that is above the level of carina airway obstruction. which is obstruction of the level of pharynx, larynx, or trachea. But why is it not the case? Because in that case, the child would have had some sort of respiratory distress or some sort of effort would have been put to overcome that airway obstruction, which is not seen here. Secondly, is ineffective neuromusculoskeletal function. So it includes both neuropathies and myopathies. Neuropathies like GBS, cervical spinal cord injury, and myopathy like muscular dystrophy or botulinum. Even skeletal abnormalities like scoliosis may be there. Now, if it would have been the case, it can be the case which can explain alveolar hypoventilation, but in that case, consciousness would not have been affected. Here, consciousness is also affected. So, again, it seems to be unlikely. So, the last option that is left is abnormal central control of respiration. So, we have concluded that it is a case of severe respiratory failure, which is causing alveolar hypoventilation, and that alveolar hypoventilation is due to abnormal central control of respiration. Now, what can be the cause of this abnormal central control of respiration? It can be either some exposure to CNS sedatives like drug abuse or some therapeutic administration, some kind of toxin, infection, trauma, or even metabolic encephalopathy. So, all these things we are keeping in our mind. Another important thing that the case told us was that the patient developed further depression of respiration after administration of supplemental oxygen. Why did that happen? You will understand this only if you know the chemical control of respiration. There are central chemoreceptors and there are peripheral chemoreceptors. The central chemoreceptors are mainly responsive to CO2 and peripheral chemoreceptors, which are more rapidly reacting mainly to hypoxia, that is O2. So in this case, since there is some problem with your CNS, your central chemoreceptors are not working, and you have taken away the signal of peripheral chemoreceptors, which was hypoxia, by supplementing oxygen. So that is where your child here worsened by giving more oxygen. So the first point to ponder was respiratory failure. There are two kinds of respiratory failures, type 1 and type 2. Type 1 respiratory failures means hypoxia, type 2 respiratory failure means hypercarbia. The second point that we were going to discuss is oxygenation. So oxygenation failure essentially will cause hypoxemia. There can be various causes behind this hypoxemia. One is alveolar hypoventilation only. This may be due to loss of neural control of respiration, obstructive lung disease, or a restrictive lung disease, or it can be these things in combination. They will classically cause hypercarbia more than hypoxia, and oxygen supplementation will resolve the problem. The second and the third thing is ventilation, perfusion, and shunt. What does it want to say? See, once your ventilation has happened, that is, the air from atmosphere has come to the alveoli. That is essentially your ventilation. The next thing that is to occur is this air in the alveoli, that is oxygen in the alveoli, has to oxygenate the blood that is coming from the pulmonary vessels. So either the blood is not going to the alveoli which have oxygen, or vice versa is happening. That is what is meant by VQ mismatch. That is the difference in partial pressure of oxygen between alveolar and arterial levels, or a shunt, where deoxygenated venous blood from body passes unventilated alveoli to enter pulmonary veins. And the last problem that can occur is diffusion problem. So diffusion problem can be due to something like excess fluid or mucus or air trapping, or sometimes even thickening of the respiratory basement membrane as in alveolar fibrosis, which are preventing the gas diffusion to occur. So these are the problems of oxygenation, that is ventilation, that is from the atmosphere to the alveoli. The second is alveoli to blood, so either VQ mismatch or shunting. And lastly, the diffusion, that is the exchange of gases. So, as we discussed, pure alveolar hypoventilation either results from central airway obstruction, in which case we said that there will be some effort to overcome that obstruction that will be seen as a clinical sign, a depressed respiratory center, that is central control of respiration, or an ineffective neuromuscular function, which can be neuropathy, myopathy, or a musculoskeletal problem. As we said that the chemical control of respiration is essentially central and peripheral chemoreceptors. While central chemoreceptors are mainly responsive to high CO2, peripheral chemoreceptors are mainly responsive to low oxygens. So central chemoreceptors, as we said, are responsive to acute changes in PCO2 by decreasing of CSF pH, while peripheral mainly to hypoxia but also to hypercarbia. Response time of peripheral chemoreceptors is much more rapid, and magnitude of response to acutely elevated PCO2 is much greater. So peripheral chemoreceptor persists over a long time. Central chemoreceptors get acclimatized. So that is why in this particular case we had seen that central chemoreceptors were affected due to disease process, and we had blunted the response of peripheral chemoreceptors by giving oxygen, which had worsened the situation. So again, going back, it was a severe respiratory failure, type 1 hypoxia, type 2 hypercarbia. The cardiac and the pulmonary seemed normal, so essentially it seemed to be a problem of CNS. It seemed to be a problem of hypoxia, that is essentially alveolar hypoventilation. Out of the three causes, it came down to central control of respiration, and we discussed the point on why oxygen had worsened the condition. So, moving on the subsequent course of this particular child. So, after mechanical ventilation and decreasing PCO2 to normal levels, and as the effect of pre intubation drugs subsided, patient awoke and was interactive. He was extubated and a nasal cannula delivering supplemental oxygen was applied. But several hours later, he became somnolent again with development of respiratory acidosis requiring intubation. So, why did that happen? Again, we committed the same mistake. We did not identify the cause or try to treat it. We simply extubated the kid, again put him on oxygen. There was some central pathology that was already blunting the central response. By giving oxygen, we blunted the peripheral response and worsened the situation. So then this time we tried to do an MRI and tried to identify the cause, and it came out to be type 1 Chiari malformation, for which a suboccipital craniotomy and decompression was done to relieve the pressure on the brainstem, and eventually the response of the central chemoreceptors to CO2 was restored. So in this particular case, we learned about some important basic points, that is types of respiratory failures, the flow of oxygen, that is oxygenation, how the chemoreceptors in the respiratory system work, and how do you come on the cause of alveolar hypoventilation.